Good morning. It's Friday morning here in California. My name is Sharda Kalanidhi. I am co-chair of the WiDS Datathon 2021. It's my pleasure to welcome you all to a very special webinar. Today we're going to talk about medical history prediction, and predicting diabetes from ICU admissions data. We currently have 110 attendees at the webinar, and we are joined in our discussion by a very distinguished set of panelists from academic research and industry who will share their firsthand experiences, lessons learned, and best practices on medical prediction. Our panelists today include Vani Mandeva from Microsoft Research, Leo Anthony Selly from MIT and Beth Israel Deaconess Medical Center, Roslyn Smith from Rush University Medical Center. Thank you all for joining us today. Briefly, our agenda, can I have the next page? Our next slide, please. Our agenda will include discussion on our data set, our real-world data science, and other resources for our Datathon contestants. Before we get started, please allow me to provide you a brief update on the WiDS Datathon and our conference. As you all know, on March 8, 2021, we will have our first ever virtual Women in Data Science Worldwide Conference. The WiDS Datathon is a technical conference featuring women doing outstanding work in data science and related fields such as artificial intelligence in a wide range of domains. We invite you to register now for the conference. The next page, please. In addition, WiDS ambassadors are currently planning online regional events to coincide with the WiDS Worldwide Conference. We are so excited that over 200 regional events will take place in more than 50 countries around the world. Additionally, the pace of the Datathon is picking up. Next slide, please. I am so pleased and proud to say that as of last night, 287 Kaggle teams, 5,044 entries from more than 70 countries have registered for the Datathon. In addition, there are more than 20 WiDS Datathon workshops around the world. We sincerely thank all of our participants, volunteers, mentors, ambassadors, and sponsors for this tremendous response. Next slide, please. In addition, we'd like to call attention to the phase 2 of the Datathon. In order to encourage deeper exploration and the development of collaborative data science innovations, the WiDS Datathon Committee and the National Science Foundation Big Data Innovation Hubs are hosting a second phase of the WiDS Datathon with an Excellence in Research Award. We invite you to have your submissions in by March. Next slide, please. We'd also like to thank our collaborators, a really diverse set from academia and industry, committed to supporting women in data science. Thank you all to the WiDS Datathon Committee. We'd like to now turn over to our panelists. If you could please discuss your background, how you got started in the medical profession prediction, and what inspires you and challenges you about this field. Thank you. Leo?
Hello, my name is Leo Anthony Selly. I am an intensive care unit doctor at Beth Israel Deaconess Medical Center here in Boston, but my research is based at the Massachusetts Institute of Technology. The focus really is on learning from data routinely collected in the process of care. And as we know, that has become more widespread now with digitalization of health records. And I got drawn into this field because out of frustration from the fact that the way medicine is being practiced around the world is based on research coming from a handful of countries. And in those rich countries, the main participants in research are the white male population. And there's an understanding that whatever is true for the white male population is true for the rest of the world. And we're hoping that we could overhaul the medical knowledge system and create medical knowledge systems in every country in the world by using and teaching people how to leverage the data that they collect in the process of healthcare.
Hey everyone, my name is Vani Mandeva and I'm a director here at Microsoft Research in Redmond. I've been in the software industry for over 20 years now, and I've spent most of that time at Microsoft building product. For the last several years, I've been at Microsoft Research, and I have really focused a lot of my effort on open data, open science, and more recently on reproducibility of AI. I believe that a lot of what we are doing in the tech industry is increasingly becoming interdisciplinary, and we have this increased collaboration with domain experts in order to make the technology that we build really useful. We're really excited to sponsor and support the WiDS Datathon this year and the WiDS conference in general. It's been an amazing movement. I have really enjoyed watching it grow. And just quickly, we are noticing questions coming in. We have a few more slides just to set some context and get people thinking about the various aspects of what we're trying to do here. Once we are done with our slides, we'll publish the questions and we can start responding to them. But in the meantime, as we go through the slides, if you have any questions, please go ahead and ask away. And we'll keep an eye out for them as the hour goes by. Thank you. Dr. Roslyn? You need to unmute, Roslyn.
Hi, everybody. My name is Roslyn Mateo. I'm a clinical endocrinologist in Rush University in Chicago, and I also have a master's in clinical research. I do have a special interest in outcomes research as well as health disparities research, especially among diabetic patients. I trained in endocrinology in Boston, where I had a good fortune of meeting Leo, who actually opened my eyes to leveraging information technology and health data analytics to improve outcomes research. So I'm very happy to be here.
Thank you, Roslyn. That was really good. As you all know, this year the challenge is focusing on predicting a particular type of diabetes, diabetes mellitus, based on data collected during the first 24 hours of admission to an intensive care unit. So our question for Dr. Roslyn is, please tell us why diabetes is so important.
I'd be happy to do that. So let's go to the next slide. So diabetes as a disease, I really want to stress the continued exponential growth of diabetes mellitus over the years. The prevalence is increasing in the low and middle income countries who are already, as we know, strapped for resources. And if you can see the demographics, more and more of our young people are actually being burdened by the disease. And if we could also see the diabetes in pregnancies affecting millions of live births, which will then translate to our future generation. And the huge drain on economic resources is also something that we cannot overemphasize. And there's deaths directly and indirectly related to diabetes, and they're on the rise, and it is not slowing down. So there's really a great importance in trying to mitigate factors and really understanding diabetes as a disease from a multidisciplinary perspective. Next slide. So really, I wanted to focus on this map. So this map, the main point that we wanted to drive across is, again, the worldwide burden of diabetes as a disease. So if you can see, it affects all nations. It's not just confined to one region, one territory. Everybody is involved, and it is not slowing down. Interestingly, if you look at Africa, one of the poorer countries, it actually doesn't show a huge percentage. But we know that diabetes is largely undiagnosed. 1 out of 2 people, so about 232 million people of diabetes are actually undiagnosed. So it's really important to look at possible information and trying to predict, diabetes just because of the burden of the disease in general and, the economic burden that it does worldwide. Next slide. And this slide is just a table on the top 10 countries or territories for adults aged 20 to 79 with diabetes. And if you can see, it's quite proportional to the number of people living in these countries. But the point that we wanted to drive across is that diabetes, again, it's a worldwide disease. It's an epidemic, very relevant to our times. So anything that we can do from a multidisciplinary perspective to try to slow down the disease is something that will spell difference in the future generation. So thank you.
Yeah, Thank you so much, Doctor. That was really helpful, really laid the context of the importance and the urgency of this problem. Our next question is for Dr. Leo. Leo, you were the guiding force behind our adoption of this data set. You know so much about this data set. What are the challenges one faces when modeling this data at the point of prediction? And what are the deeper research questions?
So I work in the intensive care unit, and our lab at MIT offers several data sets that are collected at the intensive care unit. This one is actually coming from intensive care units around the world, and it's under a project called the Global Open Source Severity of Illness Score. So severity of illness scores are typically used in research to adjust for patient characteristics, how sick they are. The most commonly used illness severity score right now, they're all coming from countries where the data sets come from. So Apache is perhaps the most popular one. It's used even outside of the United States where it was developed. And we know that the performance of Apache in other countries is suboptimal. So what we're hoping to do is that we create a repository where ICUs from around the world can contribute their data so that we together can build a more generalizable model to estimate the level of severity of critical illness of the patients in the intensive care unit. For this particular challenge, it's a bit interesting because we're not predicting the future, we're predicting the past. So it's very important for us to know what is the baseline condition of the patient when they come to the intensive care unit for critical illness, because the severity of that illness, which is really the difference between how they present and what they are at baseline, will determine the extent of the interventions that we provide to the patient. But sometimes the patient does not come with medical records. Sometimes the patient is a traveler or the patient comes from another system. Sometimes the patient is unresponsive. They were brought in comatose. So we have no way of finding out whether they have diabetes, whether they have heart failure. If they're bleeding, we don't know what hemoglobin they started off from. If their kidney function is abnormal, we don't know if that is acute or long-standing. And this will now play into what we do for the patient. So as I wanted to emphasize, it's very important for us to know what is the baseline of the patient, but sometimes that's not possible. So for this particular challenge, what we wanted to find out is, can you predict the past history of a patient just looking at the numbers generated from monitoring the patient during the first hour in the intensive care unit? And we think that diabetes is just one example, but you can abstract this and use this for any medical history that is important to the care of a patient presenting in the intensive care unit.
Thank you so much, Leo. I mean, that was really insightful, and it really brings the real issues in predicting difficult conditions such as diabetes, and it really leads us to the real world issues that we're faced with. And Vani, you have really deep experience in this area. Could you please tell us about real world interoperability issues with respect to medical diagnosis?
Yeah, that's a really good context for what we're trying to do at this Datathon, Leo and Sharada. I do have more, I do want to take advantage of the fact that we have two physicians with us today, and one of the things that we have noticed is that there's a lot of academic work and there's a lot of just interesting problems in this space that we as data scientists and engineers love to solve. But what is the utility of the models that we build in the real world, right? So it's one thing to think about these problems in the abstract, but for instance, when this competition ends, how are these models going to be used in the healthcare setting, right? So it's an open question to both Leo and Roslyn, which is, do you expect that this will be useful in the ICU setting? Will it be useful in the outpatient setting? What would your ideal outcome be, actually trying to take what we get out of this into the real world?
I think speaking with my experience in the outpatient setting, if we're able to come up with models sort of like predicting comorbidities, not just diabetes, but a lot of diseases in particular, it all boils down to prevention, really. Like knowing a disease, how can we utilize that in order to prevent more complications arising from a disease? And again, it's not just diabetes, it's a bunch of other diseases. So if we have models to predict those, then those will be very, very valuable, translated both in the ICU setting and in the outpatient setting as well. And as the face of healthcare provision changes and population management evolves, like public and private payers are also moving towards a system of reimbursements based on value rather than volume. So it really becomes important to be able to use these tools to assess, like risks and be able to predict various diseases, and those will have a lot of implications in the outpatient setting from a prevention standpoint.
Yeah.
From my end, I think there are several challenges before we could actually see more widespread adoption of algorithms in the healthcare sector. The first one would be the issue of algorithmic bias, which I think is one of the hottest topics right now in the machine learning community. So when a data scientist builds a model using health data, so for example, a prediction model, they try to build a formula that connects a set of patient features and disease factors that is mapped to a certain outcome. And what we fail to understand, or what the data scientists may fail to understand, is that the outcome's connection to the set of features, there are intermediary decisions that were made. And these decisions may not necessarily be the same across patients. So there is the real risk if we build models using real world data, there is a risk of making it permanent, making the health disparities permanent, perpetuating them and legitimizing them. So before you build your models on a data, you really have to understand, do disparities exist across different subpopulations? And if that's the case, then you should take a pause and some caution, because your prediction algorithm could be very accurate, but it's perhaps going to continue on the status quo of always predicting poor outcomes for underprivileged populations. And if that's the case, there will be a self-fulfilling prophecy. Outcomes are going to continue to be worse because you're depriving them of the care that they receive, because their prediction was they're not going to do well. And what we would like is to build a model to predict an outcome if the world were fair. If everyone has equal access to healthcare, what would be the outcome for this particular patient? And that's the prediction that you should give to the clinician, and not based on the real world data. And that's challenging. We don't have any good way of being able to operationalize how to solve the algorithmic bias. But I think we need to be able to address this before we continue on with pushing the algorithms to the bedside. The good news is that it's not happening. For every tens and thousands of publications and conference proceedings on machine learning in healthcare, only one or two are prospectively evaluated. The other thing that's important to emphasize at this point is that medical algorithms have expiration dates. These are not medical devices that you could buy and sell and you could adopt, and it will perform in the same manner over the next 10 years. You just have to do some QA every couple of years, like a CAT scan machine or X-ray machine. Algorithms are different. Algorithms will need to be recalibrated quite often, because their performance, as we know in previous examples, would wane. As new tests and treatments are introduced, as patient demographics change over time, you cannot expect the algorithm, the performance to remain optimal over time. So the idea of discovering an algorithm and patenting it and selling it, an algorithm to predict sepsis, for example, I think is flawed. We could be harming patients with that kind of mentality towards algorithms. Algorithms have to be continuously monitored when you start adopting them, and then you have to continuously recalibrate them so that you can maintain the performance. So we need to address those two issues before we could really see a more widespread deployment of algorithms in the healthcare sector.
That's really helpful, Dr. Leo. I can tell you that there has been some focus on the first issue that you talked about, where people are increasingly, there are these subfields that are coming up in the healthcare AI space, where people are focusing on fairness of the machine learning models that are being built based on healthcare data, and they are examining the underlying data. It's a fairly nascent field compared to just the, pure like machine learning piece, where we are constantly trying to increase the accuracy of our models, like you said. But I feel optimistic that there is an increasing acknowledgement that unless we address this issue of fairness and reduction of bias in AI, fields such as healthcare are never going to adopt the output of what these AI models are producing. So there is hope there, and for the data scientists, especially the ones who are looking to go into industry, I would put a plug there to say that that is something to seek out in terms of the kind of work you want to do versus just focusing on the math or the machine learning part of data science and healthcare AI. To the second part about keeping the models, alive and constantly monitoring and tweaking them, I absolutely agree with you. I don't currently have a very good understanding as to what we're doing in that space, but I do believe that in the process of trying to make these applications useful in the real world setting, and noticing that it is not easy and it is not used beyond maybe a proof of concept that you can somehow build and get someone to give feedback on, that is going to happen. There is more of a business need there for AI in the real world to continue to be used and to continue to have that application, not just in healthcare, but that is true in many other fields as well, where we need to constantly monitor and tweak the model such that they continue to be applied. So that's a really good segue into this model output that we see on the machine learning side of this ecosystem. This is a model that was generated using AutoML, where the output tells me what the algorithm was that AutoML picked. It tells me what the accuracy of the algorithm was, and it tells me, what there are some other metrics that it tells me. I haven't really captured all of them in the screenshot. What it doesn't tell me is what underlying features were ranked in order, or what underlying features are really informing this model, right? So that is where, what you said earlier about being mindful about what those features are and being mindful about that data showing the right real world representation in order to reduce bias is super important. I do want to point out that we are increasingly, at least in Microsoft Research, focusing on interpretability and debugging of machine learning models. There is an interpret machine learning model interpret machine learning library that has been open sourced, and modern machine learning techniques are used in explainable boosting machine, and there are all these different models and all these techniques that are available for those who want to explore more in this area. And these are the input data categories for this competition. You had some thoughts. I do want you to, discuss which of these categories are more likely to be useful, both in terms of increasing the accuracy of the models and in terms of what you as physicians will deem as useful when trying to use these models. Do you have any thoughts on that, Dr. Leo?
Can you repeat the question, Vani?
So in terms of these input data categories that you see on the slide, which is part of the Datathon this year, which of these categories you believe are more useful in terms of the prediction output of the Datathon, and which ones do you think are useful from a physician point of view?
I would think the last three items there, the labs, blood gas, the vital signs, and of course the demographics would be most predictive of whether the patient has diabetes. This question has not been addressed before. No one has actually looked at this. If you look at the literature, you will not find a paper that had tried to predict the past medical condition based on the first 24 hours in the intensive care unit. That's why this is an exciting datathon, because whatever the participants come up with would definitely be publishable and would be useful to the medical community. We don't know whether patients with diabetes actually behave differently in the setting of critical illness. No one has studied that, and definitely there will be some implications in terms of what happens to the physiology of a patient with diabetes, someone who is faced with critical illness.
So I agree as well with the demographic, the labs, the blood gases and vitals. Like, we all have anecdotes, but I think it will be very, very interesting to see what comes up of the Datathon in terms of being able to predict the past history of diabetes based on the 24 hours in the ICU. So I'm very much looking forward to the result of this Datathon.
Yeah, that's super exciting. We do have quite a wealth of resources on the Kaggle site. Sharda, do you want to talk about the tutorial that you have published, you and others have published, before we jump on to the Q&A?
Sure, absolutely. And I do want to mention, yes, there are tutorials, the tutorial that I've written there and the tutorial that other people have also written. We've gone through all the steps of actual data preparation and fitting a model. And there are several models. There are technical details actually fitting, like, for example, an XGBoost model or random forest classifier, all these models. And many of those models actually give a ranking of the importance of the features. So, I encourage you to, encourage participants to please look at the tutorials, and some of these models, these machine learning models, are very good at sort of providing more details of importance of the features and in actually explaining the outcome. So please take a look at that at the tutorials page. I think it's time now. We can maybe open it up to questions. Let's see what questions we have live Q&A.
Yeah, so there are some questions that that I'm starting to publish. So the first one here is, what are the indicators that a doctor will look at the data to guess if a comatose patient has diabetes or not? Is it heart rate variations, glucose max, any clues? The data has over 180 points of information, and a lot of it can be useless.
So the setting whereby a patient is unresponsive, or we really don't have any information about the patient, it does not happen so often, but it does happen when it comes to diabetes. As an ICU doctor, the first clue probably would be very high blood sugars. But having said that, I also know that people without diabetes in the setting of critical illness will also have very high blood sugars. The other thing that will clue me into the presence of diabetes is looking for the effects of diabetes on other organs. So diabetes I know would affect the kidneys. So someone with an abnormal kidney function might make me think that the patient has diabetes. But then again, there are as many patients without diabetes who also have kidney dysfunction. That's why, as I said, no one has really thought about this. And that's why we had suggested this as a topic, because this is a pretty novel question. If you ask different doctors, they would probably give you different answers. Heart rate variability, I could tell you no one really looks at that when you're working in the intensive care unit. No one is going to be looking at heart rate variability to make any decisions. And that's one reason why heart rate variability has not made it into part of clinical practice, because it's a bit very distractive to look at the variability over time. It's just not in our radar to look at that. But I would say we don't have very good answers. I gave you my best guesses. Roslyn might have some answers of her own. She's a diabetes expert, so she probably would have a better reply to that question.
That's also very challenging, because I think it's not just based on a single variable in its singularity. I think it's looking at the relationship of all these variables, because as Leo did say, diabetes does affect multiple organs. So which ones of these variables will be able to predict diabetes? It's really hard to tell, because all of them are related to each other. And patients without diabetes can also have similar responses, but then we're looking at, well, how different are the responses if you have a diabetic patient versus a non-diabetic patient? So it's a very challenging question to answer, but the short answer is that everything is interrelated with each other, and diabetes is a systemic disease. So all of those variables all together could actually affect predictability of having diabetes or not.
Yeah, and related to that, there's another question. It's kind of a long question I've published here, but if I may summarize, the question is whether the Apache comorbidity columns are realistic in the input data. Do you have any thoughts on that? So those are whether the patient has AIDS and other diseases.
Comorbidity.
Yeah. Do you have any thoughts on that, Roslyn? You can read the full question. I just published it here.
So with the comorbidities, so I think the Apache comorbidities published things like, is it cancer, and what are the other comorbidities in that column?
Immunosuppression, leukemia, lymphoma. We removed the comorbidities that we thought would be a big clue. So we actually removed heart failure or kidney disease, because that will be giving them big clues. So those were taken out of the Apache comorbidity table.
There's another question. Should we take into consideration someone's ancestry? Does one race represent different response than other races? I mean, is there a kind of a ancestry sort of race implication for diabetes?
Some races are more prone to getting diabetes, but again, it's a worldwide disease, so it affects all races. But it's definitely something that we could include and look at, because there are some, for example, Asians getting diabetes, they get diabetes at a lower BMI compared to a white Caucasian patient, but they still get diabetes. It's just a different kind of presentation, like they present earlier with a lower BMI. So the race, demographic, they definitely have a role to play in predicting diabetes.
There's another question, when choosing between like the first hour and the first 24 hours, is there anything we should have been evaluating the first hour versus the first 24 hours?
I think first hour is too limited a time. Yeah. As you know, with machine learning, the more data, the better. I mean, theoretically, these are going to be very more useful if you have a shorter observation period. That's true for any models you're trying to build in the intensive care unit. You don't want 3 days of data before you could come up with a prediction, because that it could be too late by the time you have your prediction. So it's really a matter of weighing the amount of data that can be included in the model with not waiting too long before you could come up with a prediction, because the usefulness of the prediction goes less and less with time.
Sure.
But definitely the first hour is too limited. It is too restricting.
It's true. And it's, to your earlier point about calibrating models. I mean, you have to keep calibrating it and make as it's a dynamic system. And you keep calibrating it as the patient responds differently to your medication for over time. And there's another question: is there any reference range that can be provided for vitals and labs? For example, it's not possible to have a heart rate equal to 20? Are there important reference ranges that we should look at for these variables?
So
does that change?
Yes, so that's a very common question for machine learning in healthcare. People have come up with different rules. My go-to answer is always try to work with a domain expert before you go into a data set to build any prediction model, because what happens if you don't have access to input from a domain expert is that you make all the wrong assumptions and your models are flawed. For that particular question, we sometimes just remove like 0.1% of the values at each end. And for the most part, that would be enough to do pre-processing of your data, of removing outliers that are not physiologically possible.
Mm-hmm.
There are also reference ranges that you could search, but those reference ranges, just to give you a warning, are based on healthy people. Mm-hmm. And if you're working in the ICU, I would argue that reference range taken off 200 healthy individuals is completely irrelevant to my ICU population. What I would like to know is, what does this mean? What does this lab value mean with respect to an ICU population? And sadly, we don't have that reference range given to us. The reference range that is given to us is what I mentioned, a reference range taken from healthy individuals. So we have been pushing for a much better information, a much better guide, so that we could interpret the lab results by taking those reference range from ICU population.
Yeah, thank you. There's a question: what would be more helpful and useful, a model with higher interpretability or a model with higher accuracy?
I would go for interpretability. And I don't know if this is going to be a consensus answer among.
Well, but it's not something that is being measured for the leaderboard. So
you have a particular outcome and you need to measure. No. This is the particular outcome and you need to measure thousands of competitors. So that is the kind of the benchmark that has been set. It's a different context. In this context, it's one outcome that is being modeled.
Yeah,
but it's a very valid question.
It's a great question, and this is exactly what the difference is between doing this as an exercise to really, practice machine learning on real world data versus doing this as an exercise. There's a few more questions I noticed about if we had to really make this into a product, what would it take, right? And that's where the interpretability comes into place. There's a comment about perhaps having a phase 2 of the competition where we look at the discrimination or the fairness aspect, interpretability aspect. I absolutely love that idea, and that's something that the committee will consider maybe this year or in the next year. Just to give some background, we have a lot of data scientists who have never participated in a Kaggle competition before, which is the reason why the data is so beautifully curated. And in the real world, it's really not like that. The data set is never this ready for you to go and try some great machine learning on. But that is the other reason why we don't tackle some of those more advanced problems. A part of it is also the platform, the way the metrics are calibrated for how you get to be on the leaderboard. We have limitations in the competition platforms that we use, but these are really great comments and great thoughts, from our wonderful audience.
And I would also just plug in, I would also just comment that, we do have a phase 2, which, for which we invite submissions, which are focused more on research problems. So these are fantastic research questions that the audience is raising. And, if you have a hypothesis and you would like to test the hypothesis and you have a proposal, we really invite you to make submissions for the set phase 2, and we will consider them very seriously. I think.
So there's a few more questions, and feel free, Dr. Leo and Dr. Roslyn, to look at some of these questions in the Q&A and pick the ones that you think, what is Paco to Apache? What is Apache in general? It's a very domain-specific question. You're muted, Leo.
Apache is an illness severity score. Includes variables including vital signs and labs, and usually the worst ones for the day. And it also includes some information about their past medical history. And we don't use it. People think that we use Apache to make decisions at the bedside, but we don't. And the reason for that is Apache has typically excellent discrimination, but calibration is suboptimal. And clinicians will never use a model that has suboptimal calibration, because discrimination talks about the population. So it's good when you're trying to see how sick are the patients in the entire unit, but it's not very good when you're trying to take care of one patient at a time. And for those type of situations, you need a really well-calibrated model. You really have to know about precision and recall. Those are the most important metrics before a model gets adopted in the clinical workflow, not the AUC, because the AUC is really just a very general metric of the model performance and doesn't really give you specific information that you will need to gauge how dependable is this prediction for this one particular patient. But Apache is something that is popularly used across ICUs, primarily for benchmarking, again, to determine whether the performance of similar ICUs based on the illness severity of their patients are comparable or not. We use them for research. When we say we adjust them for illness severity, that means we adjust them for Apache or some other illness severity score. But that's a broad overview of what Apache is.
Mm-hmm. It's something we teach to the students, residents, as like an illness severity. So it's something good to look at, but you're right, like it's not something that will solely affect decision making in the real world.
And then what additional features could be supplemented in the data to predict diabetes from a clinical standpoint?
Can you repeat the question? I'm sorry.
So the question is, what additional features could be supplemented in the data from a clinical standpoint to predict diabetes beyond what has been provided?
So treatments that they received during the first 24 hours and how the patients responded to treatments. But I would remove insulin, so what medications were given except insulin, because if insulin was given, then that could be a clue that the patient has diabetes. Although, mind you, we also use insulin sometimes for patients without diabetes. So definitely, if we want a better data set, I would include in there the interventions and the treatments that the patient received during the first 24 hours, and then see how the patient responded. So I suspect that diabetics would have a different response to certain treatments compared to non-diabetics. The other thing that you could look at would be some of the physiologic clocks, like the circadian rhythm. Maybe the circadian rhythm is altered in diabetes, but if you only have 24 hours, you're not really going to have a circadian rhythm.
Yeah.
But those are some of the things that I think about when we first discuss about this problem. What is it in the intensive care unit that would clue me in that this patient has diabetes if I have no access to the patient records?
Yes.
There's some doubts about the BMI data in the data set provided, that it doesn't. Okay, where is this question? Yeah, in a lot of cases, given BMI is not the same as calculated from the given height and weight. Was the BMI calculated, or was the BMI
Estimated?
Measured?
You're right. So sometimes they're able to get the height and weight, like ICU beds have a way to calculate weight. So it's an estimated weight. Sometimes it's based on, like the records there could be based on past records of the past BMI. So accuracy could be not exactly 100%, but it's definitely an important, like variable to consider for predicting diabetes. But if the question is if it's a calculated BMI, is that the question?
Yeah, the question is that the BMI values in the data set don't always match what you would get if you were to calculate it from the height and weight. So how was it measured, or was it calculated? What's in the data set? Basically, it's a question about the quality of the BMI data.
So there could be some errors. I would say do sensitivity analysis. What happens to your model if you use the BMI? What happens to the model if you use the height and the weight? And you're not required to use BMI. You could actually use height and the weight rather than the BMI and see whether that affects the modeling or not. But every time someone asks me, should I do this, should I do that, I would always say, why don't you try both and see what happens to the performance of the model on a hidden test set?
That's right.
Yeah. So we have about 8 minutes left. If participants were to vote for the questions that they would like answered, that would really help us prioritize. In the meantime, there's one question for you, Sharda. Can you give some light on some of the material you posted on the blog, like some of the tools?
Sure.
Janitor and stuff.
Sure, absolutely. So for actually fitting the model, I had there was a lot of things to do in terms of preparing the data. It was not a trivial thing. It was to actually prepare the data for a model such as XGBoost. It needs to be in a very particular format. So you sort of have to prepare the data, put it in like create dummy variables, and there's a lot that goes into. So I sort of walk through the steps. In addition, I fit models, and there's go through the technical details of fitting the model. If it's helpful to you, I can have an office hours for a few people who want to go through the technical details. I'm very happy to do that. So please do reach out, and we can have a detailed technical breakdown. Absolutely. Thank you.
So another question again about the data, how it was generated. Certain lab tests may be done or run only if a physician sees that it might be necessary. Is that something to consider when building the models?
Yes, that's absolutely correct. And what we have done in the past is to have a separate indicator variable where the lab was drawn, or that particular lab test was drawn as a separate variable to the actual value, because it is informative if a blood test was requested by the doctor. But be very careful too. Like if a certain lab test is part of your model, but that particular lab test is not routinely ordered in another location, in another hospital, then the model would obviously fail. So what you would like to do is to at least start off with the labs that are present in the majority of the patients. So these are the labs that are routinely collected. And for those labs that are less frequently collected, think twice about whether you should include them or not. Some of them could be very useful, but again, think about it in the real world when you deploy this. What about those patients where the doctor did not think of ordering this lab test? Will my model fail for those instances?
I think I have a question. I mean, in terms of like a lot of these models, in the actual, it's really a part of the broad, accessibility of the medical system. Like people who have different access to medical systems, and they have access to different levels of care. So we're really, we're really subject. That's a huge constraint that even we model builders are subject to that constraint, right? I mean, so it's like a chicken and egg. I mean, you need to build a model first, and you need to expand sort of the access to care so you can get the data to build a better model. So it's kind of it's a systemic problem. And I think model builders, we're part of this entire system. I mean, would you agree? I mean,
I could talk for hours about that. We've discovered some spurious associations and correlations in the past, and it all turned out to be from collider bias. There is some bias already of who gets into the intensive care unit. Some populations may not have access to the intensive care units, so they're underrepresented in your cohort. And for that reason, you discover these associations between upstream features that are not true, but they're there because of the representations of different groups in your cohort. So be very careful. As I said, even before you build the model, you need to understand the data well. You need to work perhaps with a social scientist and try to identify where are the sources of biases. Because if you're not aware of those, you will fall into the trap of just continuing those disparities with the models that you will introduce to clinical practice.
Then do you suggest like having multiple models? I mean, if you have like different races and they have different genetic profiles and different metabolic, sort of probabilities, different outcomes, different pathways towards diabetes, does it make sense to have, a different model for a different age group or different gender or different? I mean, does that make any sense? Or I mean, would you, or does it make sense to have one model for everybody, or different outcomes, so that you can have more, you can calibrate these models more precisely? And does that make more sense?
We don't know. This is a debate. This is a contentious topic right now. In the end, the only way to say that we're doing the right thing is if we are narrowing down the disparities. So to me, rather than accuracy as the biggest metric for success, we should add fairness. What's happening to the health disparities when I adopt an algorithm? Is it continuing? Is it widening? Is it narrowing down? If it's narrowing down, it's doing something good, because we're improving healthcare quality by reducing inequalities. So somehow that needs to be put in as a way of evaluating algorithms.
Mm-hmm. Absolutely. I mean, broadening our data set, broadening our accessibility. I mean, this is a big multidisciplinary problem, I think. And unless we treat it as such, I think we're just narrowing our focus, and we're just patting ourselves on the back. But it's not really you're not really achieving broad range outcome that we want, I think. Yeah. Let's see.
But
We
also
have
one
just a
size.
couple of go.
No,
Sorry.
I was just gonna say one size doesn't fit all. So you often wonder, could multiple models work? But I don't think we know the answer to that right now.
Yeah, it requires a lot more research and a lot more resources, a lot more data. I mean, it's a continuous problem, right? And so we have to commit to addressing that problem.
We have 1 minute left. I would love to ask this question, which is interpreting bias is a challenge in clinical settings. How can we start incorporating that aspect in our analysis?
I mean, the first thing that we do when we build a model is just to measure the performance of the model across populations that are more likely to be marginalized, and showing that the performance is the same. One of the papers that we are going to publish, it just got accepted, is showing nicely that this illness severity scores overpredict death among Blacks and Hispanics. And that is very concerning because during the pandemic, there was a directive that you could use this illness severity scores to triage ICU beds. So choose patients who have a good possibility of survival because you have limited beds and you have all these patients. So before you do that, stop. Make sure that this illness severity scores perform consistently across different populations, because we might be, again, magnifying existing disparities.
Yeah. Well, thank you so much, Dr. Leo, Dr. Roslyn, and Vani, and all our participants. It appears we've come to the end of our webinar. I hope you've all joined. You really enjoyed the webinar. I've enjoyed it so much. I've learned so much. I've gained some really interesting insights that will benefit my modeling. I would like to wish you all good luck on the statistics and the modeling. And we hope to see you at WiDS events globally and at the WiDS conference in March. Thank you so much for joining us. I think we're done. Thank you. Goodbye.